Mental health, the challenge and how to approach it. Mental health is an area of concern to all of us. While it's a true medical science, somehow it appears that it has not progressed as much or as fast as the other disciplines of medical science. Well, it has progressed, but there is some truth to the fact that it has lagged behind. There's many reasons. The most important one, that the brain is very complicated. Unlike a heart with 5 vessels, 2 nodes, and only one function of pumping blood, or kidneys with only 2 types of nephrons and only producing urine throughout the whole life, the brain has many functions. It functions as a brain, controlling the whole ecosystem of the body, and like a mind, thinking, learning, adapting, loving, hating, and planning. Everything it does is original. There's no repeat. It physically grows until the age of 40, and every one of the 850 billion neurons can have up to 10,000 connections. This complexity has repercussions. It is hard to measure the problem, like a blood pressure or white cell count. It's hard to develop algorithms, protocols, and SOPs. And it is very hard to measure outcomes in simple mathematical terms. Now, the world of business, research, and regulations doesn't take kindly to this. It is very hard for these systems to assimilate, synthesize, and respond to the complexity of mental health issues. So what is the result? Well, the result is a poorly understood, poorly paid, easy to dismiss discipline, and easy to dismiss problem. As we all know, mental health is related to not just the physical human body, but to the inter and intrapersonal constructs of the human being, our society, and our culture, to name a few. Rectifying the problems requires that multiple facets of society come together and play a role in reshaping the environment that will reduce the chances of mental disorders from appearing and improve the chances of recovery. Over the years, a complex science hard to grasp, stigmatized, underpaid, and not given its due share of attention has led to our current predicament. We are now paying the price. Mental health problems have led to a poor quality of emotional health for many people. Mental health problems lead to more physical health problems, longer hospital stays. There's increase in suicides, substance use problems. There's more broken homes, more delinquent behaviors, more children exposed to trauma, drugs, and social isolation, and there's other social and interpersonal breakdowns. Not all is lost. Things can be done, but thoughtfully and sensibly. We have to keep realities in mind, and we have to focus on what will work not only for the here and the now, but for our future as well. We don't have to go for shiny and fashionable things, but things that have a bright future, that they are sustainable, they touch more lives, they cost less, and work for all classes of society. Let us look at gaps and solutions from a systems perspective. This video is not a directive to tell people what to do. It is more organized around the problems as they exist, and it may help you see what happens if you apply a certain solution. Let's begin with the importance of time. We all know that a small untreated illness can grow larger and larger to then eventually become very severe, costly to treat, and with little chance of full recovery. One must treat early. The blue and the red lines depict the continuum of care. The field of mental health, using these domains, is trying to develop criteria to help stratify and categorize illnesses from minimal to severe. This allows to develop a systematic approach to where an illness lives in the continuum so that we can treat it using the right resource, doing the right thing at the right time. Currently, as our world has it, our EDs and the inpatient med-surg floors are serving the role of the first point of detection and even treatment of mental illness. That is not ideal. It means illness has not been picked up in the appropriate place, which should be here: PCP's offices, school and employee health, and other similar systems. Looking at early detection and treatment versus late, and low versus high cost per patient, we can create a visual representation of what we have and what we need, and where does it lie on the time axis and the cost axis. Currently, we have 5 basic systems available to the community. They're struggling, but at least working. These are high cost, low volume systems, and these are low cost, high volume systems. Let me explain the volume thing. The number of lives these systems can touch for the same cost and resources is a lot more if we treat patients earlier on the continuum as compared to later. This population served can be visually depicted like this. The other important point is that if you treat patients in this lower cost area, less and less patients would need to flow in the direction of high cost services, thus giving you a dual advantage. Another thing, notice that if we get a patient whose needs suit a point a bit beyond the ability of the closest lower level system, the needs will have to be served by the next higher system, which is EDs or the psych inpatient units. This is inappropriate use of these units. Firstly, they don't provide what the patient needed, which lay in the middle gap. Secondly, these units are overused and they get backlogged. And thirdly, insurance companies refuse payment saying that it doesn't fit the right criteria for that level. They don't care if other levels exist or not. This leads to a total disaster. Hospitals and EDs push clinicians to discharge. Clinicians worry about unsafe discharges and professional risks. They make arguments to keep the patients, so the patient is kept often. The hospitals and EDs eat the cost, but the patient still doesn't get the right level of care and either feels trapped or regresses further or actually gets delayed substandard care. Let's switch to another subject that happens when things are not going well. When a tragedy arrives on the scene, knee-jerk reactions and misperceptions are common. People develop opinions. People who lose loved ones to mental health morbidity or some tragic outcomes such as severe substance use or suicide, they often start looking at high-cost centers such as inpatient psych units, heavy-duty rehabilitation centers as possible solutions. This is because, seemingly and truthfully, at the last edges of the illness, these units would have been the solution, like an ICU. People think building more of them will solve the problems. Well, let me ask you, if you are given the choice, would you say that the first thing you want to build is a cancer center that specializes in terminal stages of cancers with very high costs, expensive equipment, and highly qualified but hard to find doctors? Or would you rather choose to develop systems at primary care level where less sophisticated equipment, average level professionals, and simpler approaches can detect cancers in a large population and get treatment started early, reducing agony, expense, and increase the chances of full recovery? To be honest, there's no perfect answer. If the problem is not common and hard to detect anyway, you may choose to build the special cancer center. But if the problem is quite common and early detection and treatment is quite possible, then you may start with a robust approach at the primary care centers. Another caveat is that if the problem affects a very large number of people, nothing will seemingly work till the critical load of illness in the community is reduced. That may take a long time. In that case, thoughtful planning as to what will shift the direction of healthcare delivery system in reducing new cases will have more impact. So let's come and take a look at the specific gaps and plan some solutions. We have these services. Luckily, we know that there are many other things at work and we need to identify them. The good thing is that several parties, including hospitals, the government, the public sector, and individual groups and large academic medical centers have already recognized their value, and they're starting to work to bring them back. We can divide these components in an early group and an advanced group. The early group focuses on enhancing early detection, treatment of minimal disease, and improving prevention and handling stable patients. This can be done through bringing standardized screens, into the primary care setting, supporting and educating primary care clinics to begin early treatment, and help them seek support through IT, such as e-consults and telehealth systems, and then by integrating behavioral health clinicians to bring mental health attention not only under one roof, but within the same visit. The second section, the advanced group, is about managing the more complex patients that need more services than general outpatient behavioral health clinics can offer. They can enhance interpersonal skills, meet patients for urgent needs, manage crises, and improve support systems. These include a lot of different components, such as internet-based therapies, bringing in group therapies, whether they are AA or DBT groups, urgent care centers that will help divert patients from the EDs and be treated in psych urgent care centers, wraparound services that are already offered but can be enhanced through the community mental health system, and intensive outpatients, partial hospital programs, longer term residential programs, rehab facilities, and special services such as ECT and TMS. All of these exist to some levels, and some of them have disappeared. We need to just bring them back. Now, several of these services are familiar to many of us. We used to have them, but we lost them, and it is important to revisit a bit of history. We need to know why we lost them so that we don't repeat those. Here's a quick summary. These worked great, but they were clinical entities, neither academic centers or research enterprises trying to prove their evidence-based value, nor were they business systems adept at getting payments, improving their reimbursement, and then finally they were not even skilled to handle regulatory and compliance requirements. The result was that they were left behind in keeping up with these extra burdens. Insurances found ways to decline every single payment that they could, and regulatory and compliance standards became so intense and labor intensive that these unable to get reimbursed systems, financially not viable, were unable to manage the overhead of administrative needs. They just simply started to fail and disintegrate, and only those lived that were supported by other systems as a cost. There are many examples of how things went. Insurances, for example, don't recognize anything that doesn't have the patient face to face. While this may apply to surgery and medicine more so, a lot of behavioral health work is done behind the scenes of the patient, with families, schools, wraparound services, and so on and so forth. A lot of clinicians know how many hours they put in after their typical day to support their patients. Another example is Medicare doesn't even recognize licensed mental health counselors and doesn't pay for their services. So this professional group basically lies waste. Life-saving treatments such as ECT and other important novel treatments require so many almost impossible criteria at times, or require simpler criteria, but they are very prolonged in time, such as lengthy trials of medications before they are approved. Again, I want to emphasize this is not medicine or surgery. For example, in medicine, a diuretic can give a response in 3 hours, but the fastest antidepressant takes about 2 months to produce some response. So while these systems struggled, but most of them disintegrated. And as they disintegrated, the chances of proving their evidence-based value also disappeared. They all had a place and brought unique supports to the overall system and contributed independently as well. Without them, we have a broken system that looks like a staircase with steps missing in the middle. As we rebuild the system, we must keep in mind a few things. There is a lot to be done, and we must not duplicate services. We need to enhance the system, and each existing party has a role to play. We need to increase and improve communication, standardize it, collaborate, and build mutually complementing systems using hopefully similar EHRs, or at least EHRs that speak to each other, and use similar screening and treatment algorithms to provide better and more elaborate care. This all is also supported by the 10-year mental health plan and the hub and spoke model proposed by the government. Moreover, if there is a possibility of developing a combined enterprise of an academic medical center with community hospitals and clinics, this can bring a lot of value. The enterprise planning will have to be thoughtfully organized and planned by professionals who understand the depths and complexities of mental health, clinical needs, and systems. This would require collaboration and complementary networking with existing independent clinical bodies, the government, and the public sector. The enterprise can bring in several strengths. An academic medical center can bring in evidence base, research, education, ultra-specialized specialist support with novel treatments. Local hospitals can create spaces, develop manpower, and develop workflows, processes, and treatment centers. These systems together can work with an involved and receptive public office, helping and guiding the government to work with them to enhance and refine the community support. I will end this now, and to conclude, I would say it's time to do it. It can be done, and let's keep long-term gains in our sights. Thank you very much.